morning, Mobile people. Good morning. Thank you. Today's program is a Compass MS Care program. We are here in Mobile, Alabama. We have our supporters of today's program. We have Bristol-Myers Squibb, Genentech, Sandoz, and TG Therapeutics, as you can see on the screen as well. Let's give them a round of applause for helping us to do today's program. Just a quickie, though. We did have exhibitors here: Alexion, Biogen, Bristol-Myers Squibb, EMD Serono, Genentech, Novartis, Sandoz, TG Therapeutics, and Viatris. So we just want to thank them for being here to, let you see their products as well. This doctor is true rural neurology. I mean, he does whatever he can do to make it so that a patient is able to live their life. And that's why I like him, or love him as much as I do, for what he does for the community, wherever the people can come to get to him and to communicate with him, and for him to keep them as upright as possible. That's a great thing, and that's what everybody should be able to have for a doctor. Dr. LaGanke is going to speak to you more about how he even got into this, because I know that's what he does, so I'm not going to impede on his ground. So let's just welcome Dr. LaGanke.
Thank you, Stuart. Thank you all for attending today on a Saturday. Hopefully you walk away with a good bit more information than you came with. That's the goal. And if it doesn't happen with the slides, then I expect some questions. Okay. Now, Stuart gave me these topics to discuss. MS treatment options that are emerging, biomarkers, symptom management, and access to MS care in rural and underserved communities. Each one of those could be a day-long talk in and of themselves. So I'm probably going to fly through these slides so that you have access to them, because when this goes online later on, you can slow it down and look at them, even if I'm speaking somewhat fast during this time. I really want you to go away with the concepts, not the specific percentages or so on. I want you to understand the ideas behind what these slides represent. So I termed it the earlier the better. I just came back from Italy, where the largest MS meeting in the world took place. It takes place every fall in Europe, and a lot of information is dispersed at that meeting. So I had from Sunday night at 10 when I got in to today to add some slides and so on. So this is the first go through, so hopefully it runs somewhat smoothly. So, early bird catches the worm. So this was the Sea of Galilee this summer when I was in Israel. The sunrise. And I'm going to go through the rural part first. And this also is underserved communities, so it applies to people who have poor access to medical care no matter where they live. But being in a rural area, I'm going to comment on rural, but it's the same issues apply if one doesn't have resources or access or whatnot. It's the same idea. So definition of rural is there, and it's 35 people or less per square mile for healthcare purposes. That's the definition of rural from a healthcare standpoint. Total is 50 million Americans. It is true if there's more than one kind, then one's likely to find, more likely to find a good one. So diversity is pretty good if you can in a rural environment. So potential benefits from having better access to care is better psychosocial and physical health, prevention of disease, improved quality of life, life expectancy, early detection of problems and treatment. These are somewhat commonsensical things that if you have access to care, you're going to be better in these realms. Barriers to access to care when you're in a rural or underserved area is matching finances and insurance and cost, availability of reliable transportation. Let's say you're in South Dakota or North Dakota, way on the other side of the state from a city. That's a major obstacle. Finding transportation maybe to get to the visits as frequently as you need to for best care. Fuel costs money, et cetera. So there's a lot of barriers that way. Taking time off from work. You take your vacation time to go have visits, and that's not a good solution. Fear of being judged if your language isn't kosher and proper and suburbia or high-class society kind of language. Some people feel embarrassed that they may not be able to communicate in the healthcare setting and don't want to go there, or they're worried about their privacy being leaked, etc. Maybe they don't have knowledge about the technology that's vast upon us. Lack of providers in the local area, so you have to go quite a ways to get healthcare. The services and transportation, getting to the doctor's office in the community if you have physical needs, etc. So these are care issues that occur when you live in a rural, underserved area. Barriers such as a limited availability of MS specialists and greater distance in order to get that, because there aren't that many MS specialists. So it's even harder when you require extra specialist care. So those who are less likely to see an MS specialist are those of a lower family income, live rurally, longer disease duration, more disabled, just much harder to get there. So with an MS specialist, though, it's been shown that someone who has MS that's mildly to more severely complicated, the benefits of seeing an MS specialist are that the treatment plan is articulated and implemented, that one's more likely to receive diagnostic and maintenance testing, that more likely are going to be prescribed a disease-modifying therapy, that rehabilitation services are offered, and other services are offered. These are less likely to happen if you have MS and don't go to an MS specialist. Now, there are some good general neurologists who do pay attention, but they have a lot of things on their plate. They don't focus as much on MS because they have Parkinson's, Alzheimer's, and pain and neuropathy and et cetera, stroke, et cetera, et cetera. They have a lot to take care of, so they may not be in the know as much or do it as often to make it a routine. So what are some of the solutions? Well, telehealth still is available. It came about, of course, during COVID, and that's something that still in certain situations is an advantage. It's not as ideal, especially with neurology, where the exam is more important than in any other situation, but still is better than not receiving care. There's online education. There are programs like this that we stream live, and then they go on the internet. So I've had a lot of patients come and say that they gleaned a lot, not necessarily from my talk, but from this type of venue, physical therapist or a dietitian or a female care doctor who talks a lot about issues particular to MS. Research pay. So if one qualifies for a study, then the study pays for your travel and all your medicine and your MRI scans, et cetera, et cetera. So that's something to look into if you have problems with access to care for one reason or another. Some insurances, and I had one in this week, they offer non-emergent medical transportation. So they'll pay for a driver to take you to the doctor. And I had one in this week, as a matter of fact. And they give you X amount of visits, depending on the plan, per year. So that's something to look into if you have difficulty with that. There's community transportation. So in our county, there's a pickup van that will pick you up and take you to your visits or take you to shopping or whatnot for a couple of dollars. Cooling vests are free. MRI scans are free every 2 years through the MSAA. So if you have a high copay, for example, or deductible with an MRI scan every 2 years, that likely can be taken care of through that program. Companies offer a lot of help if you don't have insurance or means. And then GoodRx bypasses insurance, and something to look at if your copay is too high for a particular medication, then looking to see if GoodRx can really chop that price down is worthwhile. So now I'm going to leave rural underserved care, and happy to answer any questions about that a bit later. But get to MS. So first, I like to define terms. So MS is an autoimmune condition. Attack is centered in the central nervous system, which is the brain and spinal cord and optic nerves. The major players are listed there: T cells, B cells, microglia, astroglia, and astrocytes. And the result is that there's some interference with bringing in information to the nervous system or sending information out. MS is progressive from the beginning, but the usual manifestation is relapses. So in between relapses, early on may not notice anything different, and yet often MS is progressing under the scenes. What's the impact? Over 1 million people in the US have multiple sclerosis. It's the most disabling neurological condition in the world for young and middle-aged adults. It's fatal if you don't treat it, with an average loss of life of 7 years. Many studies that say if you wait, your outcomes are worse. It's in the top 3 of neurological illnesses with suicidal ideation and number 1 in completion. And completed suicide is 7.5 times greater than that which happens in the general population. Relapsing remitting, one of the questions is who is going to go on and show progression over time, so have overt progression. It's often difficult to tell right from the beginning who's going to go on to have problems or not. There are certain characteristics early that tell us, but there are some who start out very benign looking and still progress significantly over time. If your first event left you with some baggage, you still had some neurological issues you didn't fully get over, well, that's more of an aggressive attack. If you relapse quickly, you have one, and then a month, 2 months, 3 months later, you have another one, that's a sign of aggressive MS. Or if you fail one disease-modifying therapy, meaning you take it as prescribed and you still have disease advancement, then that's considered aggressive MS. Now, there can be honeymoon periods where you don't have anything to happen for up to a few years, even off treatment, and that's kind of a dangerous situation. One might go off because they had a GI illness or something else and say, well, I felt a little bit better, I didn't have side effects. And so I might as well stay off and do well for a year or two, but then boom. And 50% of attacks typically leave you permanently different in some way or another. Benign MS is not so benign. That's one of the classifications of MS, where a person doesn't really have a lot of noticeable MS change over time, but cognitively, in a lot of cognitive testing, there are changes that occur. Comorbidities, Jeff talked about that. That means you have genes for another condition. When you get MS, you get a bonus package of other genes, like for depression and anxiety, migraine, etc. And the fastest rate of brain atrophy in the gray matter and in the whole brain is in the first 5 years. So in the first 5 years, when everything seems to be all steady, there are things happening that are chipping away at the reserve underneath if we don't pay attention. So why are we here? We're here because we don't have a cure, we don't have a fix, and because I can say whatever I want to. I'm not bound by any platform, so I can speak freely about what I think about MS, and you can ask questions freely, and I can answer them how I best see fit. I'm also here because my mom had MS and died of MS at the age of 62. So I prefer that not to happen to any of you, and I prefer your families not to have to deal with worse MS than they have to. How about challenges that people with MS face? Job alterations, loss of job, change in the ability to raise a family, strained marriage and relationships, fear of the unknown, personal physical change, change in intimacy, possible change in your gender role from the breadwinner to being at home, social isolation, helplessness, dependence, frustration, loss of control, anger, possible loss of driving, guilt of being a burden. These are real issues that affect people day to day. And it's why I'm usually late in clinic and why I usually stay late at night, because these issues are important, because they really speak to how we take care of you. I can band-aid this problem, but if I don't know what's going on underneath, I really can't get at it. And we need to know these things so we can see if we can help with them. When we can no longer change a situation, we're challenged to change ourselves. So if I used to be able to do this and I'm so frustrated I can't, I just don't move forward because I'm looking back, that's not a successful solution, right? So I've been preaching the home run of therapy since 1999. So soon after starting clinic in Cullman, I thought we finally had some treatments that came about in 1993 after 125 years of no treatments. And I just said, well, what would I want out of a treatment? What would be my ideal outcome from a treatment if I have MS? It would be that I tolerate it well and it's safe, that I don't have any relapses, that my neurological exam doesn't get any worse, and that my MRI is stable. That would be my goal. Later, about 14 years later, someone smarter than I came up with the term NEDA, no evidence of disease activity, and that has become a benchmark of all of our clinical trials as far as successful or ultra successful treatments, is to try to have none of this happen in a well-tolerated way. So when is it wise to hit the home run? When you've already gone past your peak viability or earlier in the disease state? Should we treat with a lesser medication, and if you get worse, then go to a better one, and if you get worse, then go to a better one that may have more side effects? That has to be weighed out. But all too often, we have started with lower agents, people get worse, and then we advance to treatment, and I don't think that's necessarily the right solution for everybody. So a couple different studies, one by Lublin and one by Hurst, show that after a relapse, there's persistent deficits. So in the middle panel there, you have at least a half a point worsening on our kind of disability scale that we do during our neurological exams, about 40 to 50%, and then a much greater deficit, 1 point, and this is a 10-point scale, in about a third of patients. So if we're waiting to say, okay, I'll be more aggressive when I have a relapse, or I'll start taking medicine when I have a relapse, outcomes are you have a third of a chance of being pretty significantly different after that attack. And we're trying to prevent that from happening. We want you to have the best neurological life possible. Early relapse frequency predicts conversion to secondary progressive MS over time. Early relapse predicts worse disability. So not just secondary progressive down the long haul, but also worse disability at different points. And that's how well you get over relapse and how many relapses you have in the first 2 years. So I would challenge that we should be using very powerful, effective medications early, not waiting till, okay, you're maimed, we know you have MS, now we can treat you with some really good agents. Axonal damage, which is the wire of the nerve pathway, is damaged early in the disease. Kind of what I had said earlier, that things happen early in the disease. Brain atrophy much more earlier than later. And then the MRI lesion count and the volume, or the amount of MRI lesions that you have, predicts long-term worsening. So in other words, this is sort of a picture of NEDA, where you have no evidence of disease activity. If you have complete recovery from relapse, no relapses, no MRI changes, then your outcomes are better. But if you don't recover from your first relapse, if you have a number of relapses in the first 2 years, if there's a short time between the relapses, and you have more MRI lesion burden early, or it changes quickly, then you're predicted not to do so well on the long haul. And NEDA, which is, again, no evidence of disease activity at 2 years, predicts the same at 7 years. So if we can really control disease for 2 years, if we continue on some form of therapy, we expect no evidence of disease activity at 7 years, which is why we tend to be more aggressive early. We want to control this to give you longer-term benefits. So we have a window of opportunity. So aggressive therapy early. So taking high efficacy agents early would be recommended. people on lesser agents never catch up. So we have a lot. I've been principal investigator in over 50 MS studies. And the patient who ends up being on the lesser of the two effective medications, even at 2 years when they switch to the more effective one, never catch up to the ones who started out on the stronger agent. We see that over and over and over again in the clinical trials. But there's some resistance to that. And resistance comes in various forms. Insurance companies, certain people who think you should treat MS a certain way. That seems to, unfortunately, interfere with our ability to do that. So I'm going to give you a bunch of slides that look like this that came from the meeting in Italy last week, no, the week before, sorry. That came from there, and I'm just going to kind of highlight them. So this is Dr. Stephen Hauser. He gave the talk of the MS meeting. So the first talk is kind of the more erudite, and the big person comes first and launches the meeting. So Dr. Hauser is from UCSF, well-known in MS, huge figure in the world of MS for 40 years now. So he gave the talk, and his talk is Earlier is Better, which is where I got the title of my talk. So early sustained disability is usually permanent, and the risk of secondary progressive, as I showed you in one of the slides. The benefits of treatment are present at the earliest stages, and there are several studies in clinically isolated syndrome, which is the first attack MS, with a medicine called cladribine and a medicine called teriflunomide. In those instances, had much better results when they were used earlier than not. And then radiographically isolated syndrome is if someone comes in with a headache, someone gets an MRI scan and, whoa, that looks like MS. And they haven't had any relapses or deficits, but it sure looks like MS. And medications given in that situation definitely were better than in the people who did not get medications in that situation. So, earlier better as far as treatment. And then there's a list of 6 different studies below. I'm not going to go into those, but they all demonstrate the same thing. Patients who are on a more highly efficacious medication or switched to one from a lesser one did better than the people who were on lesser agents. Many, many studies, as I mentioned. And one of the examples was the ocrelizumab study in relapsing MS, the OPERA study, that people, the 2 blue lines, if you can see those, here and here, there's a separation between the 2. The top one is patients who are on Rebif, and the bottom one is patients who are on Ocrevus. And you can see that even though at 2 years people switched right here over to Ocrevus, they never caught up as far as benefit. The lower the curve, the better a person does. So they never catch up. And then more importantly, when they looked at the patients who were on Ocrevus and went to Ocrevus in this study, so they were on it the whole time, the patients who had less time before their diagnosis, 0.62 years, and they went on Ocrevus as opposed to 3.8 years, the patients who were started on it sooner did better than those patients who had MS longer before they got their treatment. So huge opportunity, but there's also this concept of PIRA, which is progression independent of relapse activity, meaning patients are getting worse over time without any changes on their MRI scan or without having a relapse that's known. And so our NIDA may not be good enough. So he commented on the fact that we need to do better yet, because some people, even when they start on high efficacy medications early, still progress despite not having any visible MS on their scans, a thing that we call PIRA, which I'll be talking a lot about. And so there are a bunch of biomarkers or things to monitor to make sure that we're completely controlling the disease outside of the NIDA area. So on the MRI scan, for example, looking at chronic active lesions, which I'll talk about these things in a moment, and then problems in the meninges, which is the covering of the brain. Biomarkers can help us. If they're going up, then likely disease is going on, even though you can't tell. And then looking at the oligoclonal bands and the spinal fluid and other things may help us to know whether we're completely controlling this disease like we think we are when we get a scan and everything's fine. So here's sort of a cartoon of the underlying pathology that we typically see. So we'll see an active lesion right here that occurs when you first get diagnosed or when you have a relapse. And over time, then we have some B cell follicles, which are B cells that are in the meninges. And then we have these expanding lesions. So slowly expanding lesions are called cells, S-E-L. And paramagnetic rim enhancement is something that happens with iron accumulation in the outside of these lesions. And so these lesions get bigger. So we see the lesions expand a little bit. And if the radiologist isn't really looking, it can subtly happen, and it means that that lesion's getting worse, which may explain why there are more symptoms despite us not seeing anything overtly. And after that happens over time, then we have diffuse, what we call astrogliosis, or damage in a larger part of the brain. And then we have atrophy, loss of these cells over here. So this is sort of a cartoon of what happens over time with MS. And so stop. So that's my daughter graduating from Alabama this last year. If we thought, the home run of therapy and all was it, no, we still have this PIRA kind of thing to deal with. And what Dr. Hauser went on to talk about is looking at genes before you even start with MS. So if you're an at-risk person, a family member, since this is a genetic condition, can we look at genes and see things even before, in kind of what they call the prodrome period, before you even have your first lesion or attack? And the US military, the VA system, has collected hundreds of thousands of blood vials for many years now, for when enlisted first come in and then at a later point. And they've been using this in a very beneficial way, looking at autoimmune markers. I think it started out looking at lupus to see if they could see anything early and see if there are any changes over time. And what they saw was a change in the genes that occur. So you have a positive ANA test for lupus, and then it becomes more refined that you create more and more autoantibodies over time. Same with rheumatoid arthritis. Might start out with a rheumatoid factor, but then it goes to citrullonated peptides and so on and so forth. And so that has led us, that led to a trial of using Rituxan in patients who had some findings for rheumatoid arthritis before they ever had any symptoms of rheumatoid arthritis. And their outcomes over a year were better than those who didn't receive any treatment. And in diabetes, even more remarkable. So they saw these genes for diabetes, these kids that put them at risk for diabetes, started them on this medication called teplizumab, and only 7% of the kids went on to have diabetes as opposed to 43% of the others with the same genes over a short period of time. So if we can figure out someone has MS before they have MS, so to speak, and we can institute a treatment, wouldn't that be wonderful? Never have to deal with any of this. So shifting more towards, is there other ways to kind of look earlier before we have any evidence of MS? And so in MS, they looked at genes in a bunch of people. And we have found 230 genes that make a person susceptible to MS. Unfortunately, they're not the major ones yet, but we found 230, and they're mainly in the blood cells, immune cells. But there are also some alleles or genes that look at severity of MS, how severe a person's going to go with their MS. And that's with this dysferlin gene that's been identified as a cause of very aggressive disease. If you have both copies of that abnormal gene, then you're very likely to have a very stormy course with MS. So pre-symptomatic biomarker is very specific. So those genes they found were very specific. If you had them, you are going to have an aggressive form of MS. But unfortunately, it's not sensitive to picking up a lot of cases of MS. It's only a small percentage, 15% of the population have that problem. So here's kind of his clusters. So MS patients seem to cluster certain genes. Like I said, 230 genes that seem to cluster, whereas healthy controls, it's all over the map. There's no clustering. And then this one here is the more severe one that clustered in patients, 15% of patients. And that gene product shares an epitope or something on the surface of a couple Epstein-Barr virus surface molecules. And if one has those two genes, they have a much higher level of neurofilaments in their serum. Unfortunately, only 12 to 15% of patients can we find. I mean, it's fortunate in the fact the patient doesn't have severe problems, but if we could do this and pick it up in a lot more people with MS beforehand, it would be better as far as intervening with treatment. So there's this 230 genes. This was before patients were ever diagnosed with MS. We find these genes over here on the left, and then this clustering in the more severe cases of MS with this gene right here. If there are two copies, AA, then a person's very likely to have severe MS over time. So stepping away from that for a minute, and just how do we diagnose MS? Well, back in the day, in the 60s and 70s, it was Schumacher and Poser criteria. And then the McDonald criteria came in the early 2000s. And the key to diagnosing MS is that you have to have problems in your central nervous system in different places and at different times, called multiple sclerosis. So if you had optic neuritis and no other lesions, and then you had another bout of optic neuritis a few years later, that's not MS. That's one place. Although it is separated in time, it's the same place, so that's not multiple sclerosis. But if you had other lesions in other places along with that and developed new lesions that were typical of MS, then that's MS. So separation in space and time is key. In 2017, spinal fluid was reintroduced into the diagnostic criteria, more to help us diagnose people in those very questionable cases. Not like it was before. If you don't have abnormal spinal fluid, you don't have MS. And unfortunately, we still have colleagues who treat that way. And patients do not get treated if their spinal fluid's normal, which is not right. And they're told, you don't have MS. I don't know what you have, but you don't have MS. And it's not the right answer. Now, another speaker from Italy, Dr. Granziera, gave a talk about this progression of disease and such, and highlighted over the past 30 years, it's not all doom and gloom. We've made a lot of progresses in the last 30 years to diagnosing earlier, to starting treatment a lot earlier. And you can see from the very first back up here, 2000 or so, it would take us a while to diagnose people, which is now very short period of time after symptoms compared to 2 years. And the initiation of treatment from your first event was way out here and now very early. So we've been more aggressive in general in diagnosing and in treating. As another speaker, Dr. Beauvais, who is really huge into MS and pregnancy issues and breastfeeding and MS treatment to protect women around that time. She's like the head of that aspect in MS, really very helpful and instrumental in how we're moving forward. Gave a talk about the fact that there's a lot of hidden symptoms in MS. What's visible, what you can see, is just a part of it. There are cognitive issues, fatigue, pain, balance you typically will see, but sexual dysfunction, etc., are below the radar screen. So if we're relying on attacks and such, then we're missing out on a bunch. And so that over time, people have complaints of more fatigue or more mobility issues. And so in the last 12 months, 21% have worse walking, 29% worse fatigue, despite not having any relapse. Again, getting towards this PIRA, or progression independent of relapse activity. And early disability accumulation occurs. So an Italian study, a German study, and there are a couple other studies here. And what we're looking at is that early on, there's still some progression of disease symptoms, and it happens pretty frequently. So 66% of patients out of 3,000 in the German registry complained of a worsening over time. And then while on high efficacy treatments, so while on what's considered a strong MS treatment, 61% over a period of time still had progression of their disease. And then 89% of the disability that accumulated in the Ocrevus study occurred in people who didn't have a relapse. So again, this PIRA, so disability progression looks to be more caused by this silent underlying problem than a relapse causing you to be worse. And we think one of the cells that's very important is the microglia. So a microglia cell is kind of a two-faced cell. So it's really important in cleaning up damage after you had brain injury. It also can help remyelinate, which rouses lots of our interest, if it's in the right environment. So if it's in one environment, it's anti-inflammatory, and if it's another one, it's pro-inflammatory. And so how do we turn the microglia in the direction that we want it to go may help us to prevent ourselves from progressing, and also in some way may help with remyelination. So here's a microglia. It can restore homeostasis in the brain in relation to an injury, but also can promote more degeneration. If you have an autoimmune condition which keeps some inflammation going, then it's in that environment, it's going to cause more damage cleaning things up. So just a few slides on microglia. They're native immune cells inside your brain that they monitor for injuries and insults. So they have kind of little arms that touch neurons, and so they can kind of feel if things are going well, and when they're not, then they get activated. And so if you had a brain injury, for example, then they'll notice that and they'll start cleaning up the problem. They help with keeping connections well, synaptic plasticity. And like I said, they connect, or they have contact with the cell body, so they monitor them and protect them. Put it in another way, they prune synaptic inputs, which are the kind of the electricity or the electric noise that's going on in the brain. They get rid of dysfunctional networks. They protect the functional ones. They promote remyelination, and they get rid of pathogens and inflammation by sensing them in the local environment. So they were made for good, of course, so that's the good microglia. But if they're continuously in another environment with a lot of inflammation, then they end up doing things they weren't intended to do, which causes more damage. And this is sort of a picture just looking at one. Here is a healthy neuron. Here's a microglia that's in contact, making sure that it's doing well. Then one gets damaged, and we have a whole lot of inflammation occur. And depending on what happens in that environment, it can go to a guy that's going to be pro-inflammatory and create a lot of chemicals that cause more damage, or it's going to be anti-inflammatory. And this is what a different microglia looks like, one type and another type. You can see there are different receptors that are put on the surface in one situation and not in another. And the types of chemicals that come out of the cell are very different in the pro and anti-inflammatory microglia. So PIRA, smoldering inflammation, is an unmet need. We have done much, much, much better with our treatments to control relapses and keep brain MRIs somewhat stable over time, but we haven't really addressed this underlying progression that can occur over time, what's called smoldering MS, or PIRA as part of that. And I guess I used the British with a U in there, but smoldering MS occurs equally in progressive MS. They're slowly expanding or evolving lesions that are those ones that I showed you that kind of grow. And that's believed to be secondary to microglia still being turned on, and this lesion gets bigger and bigger. It's demyelination, then there's partial remyelination, and when that fails, then it expands further. And so that seems to account for an MRI scan where you see a bunch of little lesions, and then over time they're all grown together, where you see this blob instead of this discrete lesion. And this process is believed to account for that. There's also a concept of silent MS where there's cerebral lesions occurring. So 9 out of 10 lesions we know typically don't cause you symptoms. That's why we get MRIs every year when you're feeling well, to make sure that our treatment's covering these silent lesions that are occurring, because if we're not, then we probably need to change what we're doing. We want total control as best we can of any activity going on in the brain that's adverse. And the brain has more atrophy over time, and this one group out of Brazil showed 20% increase in atrophy over 7 years, even though there weren't any relapses or clinical events. So PIRA I talked about a good bit. There was a study done by Portaccio that I'm going to show you on the next slide, but it said that accounting for progression between 6.5 and 17 years of having MS was more related to PIRA than it was relapse-associated worsening, or RAW. So if you had a relapse and you never fully recovered and got worse, that you kept over time, that accounts for 17.8% of the progression, whereas PIRA accounted for 27.6% out of the total people who progressed. And here's a picture of that, which shows patients who didn't have, we all have some brain atrophy over time, so that's expected, all of us do. So patients who were stable, didn't have any relapse and no worsening on their scan is here. Patients in this study who had some relapses, didn't worse, or they didn't have any relapses and got worse, their scan was like this, and patients who worsened and relapsing were here. So you see that even patients who weren't relapsing and worsening had changes on their brain scan. And those who had relapses but got everything back, or so we thought, are here, but someone who didn't have any disease activity was like so. This concept was talked about a couple of years ago, but not really. I haven't heard it talked about in this way, but I think it's helpful to see it. You can have it within the first 5 years. You can have it later than 5 years. Pure PIRA is that you have worsening of your disease with no new lesions. T2 PIRA is you had new 2T lesions and got worse, but it wasn't due to where the lesion was. So if you got weaker in the right arm, you had a new lesion on the right side, which wouldn't cause the right arm to be weaker. So you could have a little bit of advancement, but it didn't cause the progression. So they call that T2 PIRA. So back to Dr. Granziera stated, we're not really sure that our really strong agents like Ocrevus, they certainly help the relapse-associated worsening, as you can see, but not the PIRA. So some patients got worse despite not having any relapses. That was due to PIRA. And the patients who definitely had less relapses, they had less worsening, but that was relapse-associated worsening. So the Ocrevus helped a patient from getting worse from their relapses, but did not seem to affect too much the worsening that happens under the scenes, or maybe through the microglia. So the way we kind of look at PIRA, how do we know someone's worsening? Well, we do the disability exam, your neurological exam in clinic over here, and some other disability assessments like walking speed, doing certain cognitive tests. We can assess whether you're getting worse or not, even without change. And then some imaging things like the slow expanding lesions, or the pearls is what they call PRLs, paramagnetic rim lesions, which is iron that's accumulated. This is not one that we routinely see on our commercial MRI scans. We can see slowly expanding lesions. And then we look at atrophy in general, and then there's some other fluid biomarkers. And there's one called Octave that we're really interested in that we've been using in the last year that hopefully I'll have time to talk about. So slowly expanding lesions and paramagnetic rim lesions are in this lesion here. It's getting worse and worse over time, and that may be what's causing this underlying progression that's not due to a relapse or a new lesion, but it's an expanding old lesion. And in that rim, we see microglia. And macrophages are a cousin and may turn into microglia. So we see the players in that area as being microglia related. So they're a potential marker of this PIRA or smoldering inflammation. And this study was looking at MRI lesions over time and how a lesion may have started this way and then got that way over time, but they matched them really well to show that the lesions were getting bigger. And it was observed in 83% of patients with relapsing disease. So pretty common thing that happens. I'm not going to kind of belabor these two, just to understand the concept that if you have those, you're more likely to have disability, more likely to have secondary progression over time, the more cells and pearls that you have. So again here, and the cells seems to be the more prominent one, because the paramagnetic rim lesions occur and then they go away, and the slowly expanding lesion is still expanding. So the PRL is just a part of that, and so you don't see as many pearls as you do cells. But the key driver is the cells plus the pearls. If you see them both, then you see this. Sorry, I think this light's gone out, but you see the pink curve going up. Now. There's something called the BTK pathway, so Bruton tyrosine kinase pathway. And this pathway seems to be important in both B cells and in microglia. So there are 7 BTK inhibitors that are being tested right now to be approved in MS to control MS relapses, but also stop this progression in the microglia. So they have an impact also on the right-hand side in microglia and macrophages, and we haven't had any medication that we know of that works on that cell type to date. So then another talk was looking at biomarkers. Can we capture PIRA in a way? We can draw your blood and say, hey, your neurofilament levels are going up. I think, even though you're feeling well, I think your MS is kind of on the move. And so this was a presentation from Switzerland. And I don't want to mispronounce his name, but he showed a lot of different biomarkers that we're looking at before PIRA even. You can see in the graph that the levels of neurofilament were going up at the time. And with NMO, which is a kind of a condition that's similar to MS, we're kind of finding some biomarkers that let us tell us that condition's getting worse despite treatment or so on. And so we hope to have the same sort of thing happen in MS if we have the right biomarkers. And again, this is a 6-year study. 30% of patients with relapsing disease had confirmed progression over the 6 years. They had worsening on their exam that we could tell. 23% of it was due to, or 23% of the patients then had PIRA, and only 7% had had a relapse that led to that worsening. So again, this underlying driving PIRA thing. So serum neurofilaments and GFAP, which is another biomarker, they're both really being looked at as biomarkers of progression of disease in different ways, but kind of looking at that underlying progression. Same thing, not going to go over that. And then targeting BTK may be very helpful. And here are the 7 medications that are currently being studied and the phase of study that they're in. So 4 of them are in phase 3 studies. We happen to be in them in our clinic. So it'll be about, hopefully within a year's time, we'll have a final readout on these and have first time to be able to commercially administer this type of a treatment. And this BTK inhibitor was really invented for cancer, trying to help in certain kinds of cancer. And so that the one in the orange, again, this isn't working with the light. So the one in the orange had a lot of different receptors that it was blocking. And now the ones that we're testing in MS, there were only 2 outside of the one that we wanted to inhibit with the evobrutinib. Tolobrutinib, there were 11 that were outside of the 250 ones that the orange one bound. 2 additional kinases with Remi, and then fenebrutinib had 3 additional. So they're much, much more specific for the places we want to target in MS. It's not targeting a lot of different kinases, a lot of different cells, which if you're targeting tissue outside of the brain, you're going to have side effects. So that was the problem with the orange one. You get a lot more side effects if you're binding to all kinds of receptors in your body or different places in your body. So these are very specific for where we want them to go in the brain, and they're small molecules, so they get into the brain. A lot of our other treatments, the bigger ones, the antibodies don't get into the brain to work there. They keep bad stuff from getting in, but these work inside the brain as well. We strongly suspect. They get in there, we know they do. So evobrutinib has, this presentation talked more about that than the other one, just because there are 2 of them that had phase 2 data already available, and this was one of them. And it showed clearly that patients who were on evobrutinib had the bars were less high, which means less active lesions over time. So that was a very good effect on active disease, relapsing disease, so to speak. And then they looked at neurofilaments and looked at those cells or slowly expanding lesions and saw a very profound impact on those as well. So taking care of the relapses, which does lead to some disability in people, and also taking care of the microglia inflammation maybe, and we'll see over time what that means. Safety was very good. There were 6 patients who had some liver function abnormalities, but none of them serious. They're all asymptomatic and reversible, but unfortunately, through this process, a couple of them had some mild elevation of liver function tests, and the FDA halted the studies for a little bit, now starting back again. But there were asymptomatic liver function abnormalities. They just wanted to be sure they weren't missing anything, so they're back on track now. Most of them anyway. So here we're looking at the possible effects of a BTK inhibitor on the focal lesions, on the slowly expanding lesions, on the diffuse white matter inflammation, and the meningeal inflammation, which is where the B cells are, because they get into the brain. And where those B cell follicles are, it can attach to the B cells. It works on the B cells. So has a multitude of areas where this type of treatment may be helpful in MS. And tolobrutinib's very similar type of thing. So this is another BTK inhibitor, just kind of showing that there were positive results, which now have led to a phase 3 study, which is the one we need to get to approval. So if we fix PIRA, do we control everything? We stop relapses and then we take care of PIRA, is that it? Yeah, exactly, we wish. No. So when a person gets worse, we've been ahead of the curve in a lot of things. We talked about NEDA and the need to treat aggressively for 20 years before most did in our clinic. So we kind of trying to keep an eye on things and be ahead of the curve. I think some of PIRA is not probably PIRA, and everything's being lumped into PIRA. But someone can have worsening of their MS if their reserve gets chipped away at. So aging, we all lose neurons as we get older. So if we were relying on some of those normal neurons to pick up the slack and we're aging, we might lose some of them and we may get a little bit worse. That's not going to be controlled by this process. Or if someone has a stroke or has other stressors on their system, diabetes, et cetera, that's likely going to lead to some progression of disease and dysfunction. Is the original lesion wearing out? Is it just wearing out? Which may be along the lines of PIRA. Is that the cause? Or is there new damage? Or are some of those comorbid conditions, anxiety, depression, etc., insomnia, leading to more damage in the brain, which leads to progression of the MS? Certainly, our disease-modifying treatments have definitely changed the projection or the progression and trajectory of MS. We're much better off having had treatments than we were 15, 20 years ago. Looking at the number of people who get secondary progressive and have worsening outcomes over time, we've definitely made some significant advances, but we still have a ways to go. So here are comorbid conditions. This is the frequency with which people with MS have these problems. And some are really, I'll get on my soapbox for a second, Stuart, but depression and anxiety, I think we do a disservice in this country to people with depression and anxiety disorder. We treat them like it's their fault. You're weak, you're not praying enough. Johnny across the street's in a wheelchair. How come you're so sad? It's your fault that you're feeling that way. We don't do that to Parkinson's patients, diabetics, yet they have a chemical problem, insulin, dopamine. Anxiety is GABA, depression is norepinephrine or serotonin, medical condition, chemical pathway problem. Why do we treat those people differently? And they feel guilty. They don't want to bring it up. They feel ashamed. And that certainly doesn't help their well-being. So those are legitimate problems that certainly stress makes it worse, but stress makes all those conditions worse. Parkinson's, diabetes, everything. So if a mental health person helps to combat how you deal with stressors and so on, that's great. That's a positive outcome. But the stress doesn't cause your anxiety disorder, depression. You have a physical problem of the brain. Through those chemical pathways, they require treatment for your best quality of life. So with these things, if you don't treat them so well, what happens? So chronic migraine, there are definitely changes in the brain. There are certain areas of the brain that are damaged and atrophy. There's mitochondrial dysfunction, and the mitochondria are what give you energy. So more fatigue. If you deal with chronic problems with migraine, there are changes in the brain. Long-term insomnia, increased risk of Parkinson's, Alzheimer's, hypertension, diabetes, heart attacks. These are studies that have shown all of these things. Impaired cognition, fatigue. So those are the things that drive PIRA that a lot of those doctors talk about. They're getting worse because their fatigue's worse, their cognition's worse, some other subtle things are worse. Well, is it not because they live with this all the time that wasn't treated? Maybe it's not PIRA, maybe it's this. And if we fix or help these things, we help a person not progress with their MS over time. Long-term depression, chronic fatigue from long-term depression, less energy, sleep's off, hard to concentrate, remember. These are long-term things that happen in people who have poorly treated or undertreated MS or depression. And anxiety, same sort of thing. It leads to changes in certain areas of your brain, the amygdala, the hippocampus, that have been well shown over time. Your ability to handle with stressful things becomes less over time if you've dealt with anxiety all the time. So now I'm going to kind of move into symptom management. So the cartoon says, I'm so sick of not being understood. And the person says, what do you mean? So these are some of the hidden symptoms. I'm not going to read them all. In MS, things that you can't see when you look at somebody. Can't tell that they have these things going on. Like Dr. Beauvais showed with the iceberg and the things that are underneath that nobody's looking at or seeing. Well, I guess I'm going in reverse build here, but sorry about that. And then here are the common ones. Of course, a lot of those hidden ones are very common, but there are some other ones that are common that aren't so hidden. Fatigue, number one disabling symptom in MS. Number one reason people get on disability, not being in a wheelchair, not being blind, fatigue. Significantly impacts your quality of life. And people who are around you don't get it because you don't look tired. You don't look like you've been up 5 nights. You just have no energy. You don't have anything to go. So to give credit to the people around you, how do they know? You don't look tired. That just doesn't fit how we think of tired, right? And until they understand this disease or care to give you credit for what you're telling them over time, it's hard to understand what that means. But it's very, very real and very life-altering. There's a mitochondrial imbalance. It's not that you're sleepy. You got to pace yourself in this busy world. And address any other things, like if you have spasticity, that chews up your energy. If you're not sleeping well at night, that causes more fatigue. If you're in the heat too much, there are a lot of things to address that can assist with fatigue. It's not just your MS fatigue is there and we'll just give you a drug for the MS fatigue. We should address these other issues as well, which are going to help give you more energy. And here are some various things to do that all are part of fatigue management. Speech problems. A lot of the times it's coming up with the right word, and people think they have a memory problem. I just have more problems with them. But it's really in the speech pathway. It's really in a different pathway than your temporal lobe that's causing this problem. It's in the frontal lobe. You form the words in the front. They have to go over to the middle of the frontal or the back of the frontal lobe to then be articulated, and there are a lot of lesions in the way. So you form the word, but you just can't get it to where you need to say it. And so you're trying to come up with alternate words. Or thought blocking, where you have a thought, you're talking, and then vanished. Hit the wall, hit that scar, gone. And you can't remember what you're saying. I think we've all had that once, occasionally, but with MS, it's much, much more common. Cognitive dysfunction, fatigue, managing fatigue and depression helps a lot of the problems with fatigue. If we with cognition, if we optimize energy and help treat depression, many people are much better with their cognition, and they contribute significantly to cognitive dysfunction. So we pay a lot of attention there because unfortunately there aren't a ton of things to do to work at the cognitive problems. There are certain things mentioned there that you can work on. Medications have been pretty underwhelming as far as that goes. Paresthesias or tingling. You can have burning, all kinds of nerve pain, trigeminal nerve in the face, where people like my mom lost several teeth because they didn't recognize that it was trigeminal neuralgia and thought it was a tooth problem. That happens still today. Had someone in this past month had a tooth taken out and it was trigeminal neuralgia and didn't need to have it taken out. So this is a problem. Fatigue. Be one-sided, both-sided. You just want to know if it's both sides, it's at the same time, or starts in the feet going up or the arms going up, it's probably a spinal cord lesion. And if they image your brain and didn't see anything, they imaged the wrong place. Just a comment on Empira. So when you have a scar, this potassium channel leaks out when you use it more, so then you get more fatigued easily. So going to the mailbox, you might start out first several steps good, and then it gets worse and worse. Fatigability is what we call it. This is part of the concept of why that happens. When people go on Empira or dalfampridine, quiets that leak of electric signal out, so more signal goes forward, so people have better endurance. And this is one of the most underutilized medications in MS. It's a shame people aren't offered this for their endurance. They have endurance of speech or thinking or strength. This medication can be very helpful. It's a royal pain in the you-know-what with insurance companies. Royal pain. Has been for a few years, ever since it went generic, and they make you take generic, and then they use things like copay accelerators. They don't let your copay be, when the company helps to offset it, they don't count that as being against it. They charge you more money. It's just a royal difficulty. So if the clinics aren't willing to take a good bit of time and resources to go after this, sometimes it doesn't happen, but it's there and you should look it up. Spasticity, Jeff talked a bit about that, different things to do about that, different medications, exercises, etc. Bladder dysfunction, really common. Consequences, social isolation, loss of intimacy, poor sleep, skin breakdown, frequent urinary tract infections, a major problem as well. Timing of fluid intake, and our seminar that was in Cullman in July, we had a urogynecologist who taught me a couple of things in his talk. One is if you go to the bathroom a lot at night, you don't necessarily during the day, but at night, and you have swelling in your feet, well, that swelling goes somewhere, and it goes to your bladder at night. So taking care of that swelling during the day with good compression hose or other things to keep it from accumulating will make it so that it doesn't have to go to your bladder at night because it's not there. So that was a pretty good point, and some of our patients have benefited from that. Also, he said to prevent those recurrent urinary tract infections, something called D-mannose. It's an over-the-counter supplement. Works very well at protecting the bladder from binding the bacteria and can help reduce the number of urinary tract infections that a person has. Then the bladder might be lose its nerve supply. Instead of a spastic bladder, it just doesn't do anything. And we have some medicines to try to help you to empty better, but sometimes catheterization, unfortunately, is the end result because there's no muscle really to the bladder, and have to use a catheter. Not talked about a whole lot for probably a lot of reasons. Doctors' hesitancy or discomfort in bringing up the topic, but intimacy is a very important thing. So if that's something that's affecting your quality of life, I ask you to be bigger than the healthcare person and bring it up if that's an issue, and talk about it, because we have several different things that we can do to assist in that. There's now the pink pill for females, so there's moving along that way. Lots of other things to do. I'm trying to get through somewhat quickly. Dysphagia or difficulty swallowing. There are different things to do. So you'll have these slides, to go back to, refer to back later. Pain, that's going to Auburn and losing. That's a very, very painful thing. I was there that day with that picture, so that was not pleasant. So pain. Neuralgic pain, like trigeminal neuralgia, very painful. It's lancinating, burning, electric, like a sunburn. Also the itching, this itching. I've had a bunch of those here lately. It kind of comes in groves over the years, but itching you can't get to. That's probably histamine release from a damaged nerve, and it just, you can't get at it. So the antihistamines and or the anti-seizure medicines are best in controlling the itching, just like they control the nerve pain. So same treatment is sought after for the central itching. So I'm almost done. Newish treatments. So some are newer than others, just kind of give them a little bit of a word. So Briumvi is a modified Ocrevus, so it's genetically modified at the stem of the antibody, which may lead to less reactions, allergic reactions or infusion reactions with the treatment. So that's, and it's also the cheapest of the disease-modifying treatments now, so that's a welcome medication to the crew. Bifurtim is a post-Tecfidera metabolized medicine. So Tecfidera gets broken down into bifurtim, so to speak. And so that's a medication that can be used if you had good success with Tecfidera and maybe had some GI issues or other issues. This might be something to try to see if that fits. Ultomiris is in the NMO space, but been approved and been shown to be quite effective with NMO. Tasenso is Gilenya or fingolimide in an oral dissolving tablet. So generics, I'm not in favor of generics for the management of MS. Now symptoms, fine. The disease modifying therapy, I'm not fine with them experimenting on you so they can save money. So we had to do all these clinical trials to prove that medicines are beneficial. When you get a generic can be 80% as effective. Wasn't tested at 80%. So if you have a relapse and a 50% chance of not getting better from it, that's experimentation, and I'm not about that, nor in stroke or seizures for that matter. So I don't think we need to be taking generic disease-modifying treatments. Insurance companies kind of drive that. They save money. Often you lose your copay assistance from the drug company and you end up paying more. You pay more for the generic. They pay less. With possibly less effective, so a generic only has to be 20% on either side of the brand percentage. So it could be 80% as effective. It can be 120% the dose, which with some of these side effects, may have skin cancers with some of the treatments, then you're having a higher risk of that when you have more of the medication. So in my opinion, we don't need to be experimenting with generics in MS. Now, teriflunomide is the only one, or Aubagio, that I'm okay with, because a 50% of the usually used dose is approved as beneficial. So if you only got to 80%, that's still better than the 50%, which was shown to be effective in MS. So that's one that I'm okay with, but any of the others I'm not. Zeposia is a branded alternative to Gilenya. It's not Gilenya, but it's in the same class. Has some niceties to it, so you don't have to have first dose heart monitoring, et cetera. And it's very effective. It's in the high efficacy category of medications. Mavenclad is you treat for 5 days, 1 month, and the next month, and the next year do the same, and then you may never need to be treated again, depending if you don't have any more disease. So it's a medication that is really good in certain situations and a lot of situations, but maybe when one has been stable for 20, 30 years, 65, questioning whether we need to take treatment anymore, you take this, well, that might just help you to go off without having to take any more medications. So there's different places where that can be uniquely beneficial. Subcutaneous Ocrevus is being looked at. The BTK inhibitors I talked to you about are those that are in trial now. There's also a biosimilar to Tysabri that has been approved. It'll be available, looks like, this upcoming year. Biosimilars are different than placebos. There's a little bit of ambiguity because they're tested in a same kind of system. Let's say with this biosimilar from Sandoz to the Tysabri one, they're in the same kind of cell, produce the same, and they do some kind of chemical testing to make sure that the molecule looks the same, and so on, that it's expected to be very, very close in function to Tysabri. That's the expectation, and biosimilars have been used in other conditions, and that's the expectation. Of course, we don't have any experience in our space with this, so something new is a little different for us, but it has been used in other disease states successfully. So we like as many options as we have, which may lower cost. We'll have to see if that's something that's a very good alternative to Tysabri if it comes to that. Some of the oldies, these three are high efficacy medications. So again, the earlier the better. So not waiting with Copaxone and interferons early, and if those fail, then go to a pill that's modest in effects and then go to something else. These three are very effective. I've just put in for a presentation at the American Academy of Neurology meeting in Denver in April for our first 300 relapsing patients with Lemtrada, showing $150 million cost savings to society. Those individuals 60% better than when they started, 10% worse, and 30% stable. So that will be hopefully forthcoming. So last kind of philosophical stuff. You have a unique fingertip. So you're going to be a light to this world no matter what happens. You are going to influence the world the way you do. Focus on that. How can I make this a better place? Shoulda, coulda, used to is in a place called the past. That's back there. Life's here, forward. So I used to be able to do that. I should have done that. That doesn't have anything to do with where you are right now and moving forward. And if you're looking back, you can't move forward. People who say I'm a burden. Well, it's almost like a personality disorder. And that most of the time, and it seems like a selfless thing, but you ask the person, so you feel like you're a burden. Yes, I'm a burden. He or she has to change their schedule. They can't do this anymore, da-da-da-da-da. And I said, so if they were in your shoes and you were the healthy one, they'd be a burden to you, right? No, they wouldn't be a burden to me. Oh, so you're better than they are. So you can handle them, but they can't handle you. Is that what you're saying? Or you don't ask for help. You're not blessing them, because when we do for others, we're blessed. So when you don't ask, you're depriving them of the ability to help, which is a gift and something that we feel better with. When we go to bed at night, we don't feel better about the Porsche we got. Well, maybe some, but we do feel better that we help someone. We helped that lady across the street. Feel much better about those things, helping someone, than about things that we've obtained or things for us. So when you allow someone else to help, you're giving them a gift. You're also very inspirational. So, who the person was back there who works, children, trying to figure out, gets up at 5 a.m. I mean, God bless you. That's remarkable. It's hard enough for people who don't have MS to do that. So for you to continue to do that, that's inspirational to everybody around you. And good job. Keep it up. We don't exist. We don't just simply exist. But we can have a big influence, is basically what this says. What you become the next moment is on you. If you want to feel sorry for yourself, that you can do that. And what Jeff was talking about earlier was about exercising. I mean, he was speaking to me. It's been on my list for over 6 months to get back into exercising, and I'm guilty as charged. But it's on me. It's on us to do that. Right? It's on us. We do what we value. The action or the inaction is what we value most. So it's trying to put your value system in the right place. That's what he was basically talking about, if that's something that's important to you. And lastly, everything can be taken from a man but one thing, the last of the human freedoms, to choose your attitude in any given set of circumstances, to choose your own way. And that's from Dr. Frankl, who was captured in Auschwitz and had to endure that experience and said, I'm not going to let them make me bitter. They've taken enough from me. I get to choose how I come out of this. I have the power. That's my freedom to do that. They don't own that. They don't own how I'm going to feel. I own it. And a sunset in Captiva. So that's it. So thank you very much for your attention. Kind of a whirlwind. Happy to answer any questions.
Let's give Dr. LaGanke a big round of applause. Give him a bigger round of applause. That was awesome. X amount of time. By the way, I'm going to take questions from here first. We've got like 20 or 30 questions online. Listen, I noticed one thing missing from one of your slides, and I just don't know if it was an oversight, on your high efficacy. The O.
Yeah, so I talked about Ocrevus several times in there, and the high, versus relapse, and that they never caught up if they were on Rebif. So,
all right, thank you. A person asks, does the study about Ocrevus also apply to Rituxan?
There have been many studies, so I'm not exactly sure.
You spoke about it early on,
which one applies there, but there are a few that I talked about, and it would be expected to. So it works in this very same kind of fashion, though not formally tested the way that Ocrevus was. But it works as a B-cell depleter, and as long as it's depleting B cells, for most of the part, it should do the same thing that Ocrevus does.
Okay, thank you. A person is basically saying, I got to take it away from personal to general, and that is that no new lesions, but have had and still continue to have a lot of old lesions, and she or he wants their doctor to prescribe a new medication, and the doctor won't do it, and they live with a lot of stress, or whatever. And what should they do, though, about pain that they're getting every single day, or should they be put onto a new disease medication?
Okay, so old lesions are just like scars in your skin. They're not going to go away. So they're going to, by and large, remain there. So having no new ones and a stable old set, well, that's about the best we can expect from our treatments at this point. And if you have old symptoms from those old scars, well, then that's what symptom management's for, to try to take care of that symptom that's related to the old lesion. Going on a new treatment, the primary emphasis wouldn't be on getting better from that symptom. Now, some people definitely improve some when they change therapies, but it's a smaller percentage, and that's not the expectation going in that that's going to happen. So it's being more aggressive at treating the symptoms from the old lesions. Now, if there are new lesions that have occurred even without seeing new disease, that's a different story, and that's certainly a debate to talk about changing treatment.
Great. Thank you for that. What do you say to a person who really has no symptoms and has a very low EDSS, but is on a very low efficacy medication, and that person wants to make sure that things are not going to change? Do you suggest still going to a higher efficacy medication?
Yeah, that's a very good question. We've had people who've been on lower efficacy medications who have done well for long periods of time. That's the difference between individuals and population statistics. So statistically, people aren't expected to do as well on lower efficacy. If one's done very well by all accounts, no signs of anything on the scans, feeling well, and maybe doing some cognitive testing and so on, and there's no advancement, well, it'd be hard to argue to change that therapy. But I think it's something that needs to be kind of asked periodically, and maybe some of this information is something to be discussed with a healthcare provider about, hey, I see that even with higher efficacy medicines, there's some progression and it's worse on lower efficacy medications. Is this something we need to kind of address, or should I think about it, or what are your thoughts about the matter?
Thank you. Did you speak about neuroplasticity before?
Before
today? Before now, during this program?
The second?
Earlier.
I did talk a little bit about synaptic plasticity and so on with microglia. And I did think about it when Jeff was talking about thinking about emotion and actually doing emotion, and thinking about it's not good enough. But thinking about it actually does kind of move in that pathway. Neuroplasticity is if you use a system repetitively, you likely can get better and have more neuronal strength in that. And so if you're weak, the tendency is not to use it. But you should be using it or trying to use it, thinking about it and trying to use it, because the first problem is an electric problem. You don't have electricity to the muscle to move it so well. But what happens when you don't move it is then you get an atrophy problem. And now you have a compounded problem, you have a double problem. And that's where also people can get weaker. It's not PIRA, it's atrophy from disuse. So and that can help with neuroplasticity by using things over and over, whether you get in the pool where you can't walk and land, but maybe you can do some things in the water, and all kinds of different things from a physical therapy standpoint that I think can help with neuroplasticity. So yes, I think that we need to tap into that as much as we can.
Great. This next one I'm going to make into a 3 or 4 part question that you'll love. All right. So for people who are above 50 or above 60 who are being told that they have to come off their medications, some who may be stable and some who may not be stable, and the fear of those that are using medications that are above 60, is it safe? Should they continue? And should they go forward with doing what they're doing, or should they listen to their doctors and get off?
Well, I can't speak to particulars and particular medicines and particular situations in individuals. If they have other comorbid conditions where staying on a medication may cause them some issues. But just on the surface, we want you to be stable. So if you're stable on a treatment, doing well, the thought to come off it, if there's no other reason for it, sounds a little bit foreign. If it's like a blood pressure medicine, you go on a blood pressure medicine, blood pressure is well controlled. Well, you're well controlled, let's come off your blood pressure medicine. It doesn't really make a lot of sense. And so unless there are particulars in those individuals, if it's kind of a philosophy that, hey, you're over 50 or 60, you're a bit older, you have neurosenescence, which means the nervous system's getting older, doesn't respond as well, maybe more, or immunosenescence, having maybe more susceptibility to infection, well, then the proof's in the pudding, and a number of people older have remained on these medications and not had problems. So again, if you're seeing infections over 60 repeatedly but not having any change in your MS, and it seems to be that maybe the medication you're on is doing that, well, then sure, you consider changing that therapy. But by and large, we haven't seen grand toxicities from higher efficacy medicines in our patients who are older. Plus, 60 is just a number. You look at two different 60-year-olds, one's very vibrant, one's not. So just the age itself shouldn't be an arbitrary cutoff, in my opinion.
I agree. All
right.
right.
I'm 60, so here you go.
I got you beat, though. All right. When do you think the first BTK inhibitor will be available or be approved?
It's looking like last quarter of next year. So about a year or so. It may be different, but that's kind of what it's looking like.
All right. Next, how do we really know if the DMT we're on is needed any longer?
Yeah, that's a great question. If people are stable for 20 years, haven't had anything, and are up in years and want to come off, that's something that we struggle with a good bit, answering that question. And it's person's risk benefit philosophy. If you're stable, there are no reasons to come off the medication, then maybe that favors, hey, I'm here I'm doing so well for a reason, and I don't want to try, just do that for the sake of coming off. Although we don't want people to take things that they don't need, and it's cost to society, and it's also putting something in your body. So that's a difficult thing to answer. We don't have grand correct answers. There were a couple studies that were conflicting. One that saw 80-year-olds start having relapses again when they come off their treatment at NYU. That was not a good thing. And then they repeated the study and very few did. So trying to isolate what are the characteristics that would predict a person to be able to come off safely. There's a bunch of work being done with that. What's your history of MS, how long you've had it, what your lesion burden is. So there's a bunch being studied for us to advise safely to stay on or to come off treatment, but we're not there yet.
Okay, thank you. Next is concerning stem cell treatment. As an early treatment option, how does it compare with Lemtrada? If Lemtrada doesn't work, can one do HSCT soon after, and neurofilaments as markers? What is smoldering MS versus relapse remitting?
So the stem cell transplant can be done at any time. Not that it's going to be covered by insurance and is quite costly, but that's a very highly effective treatment to kind of reset your immune system. And hopefully we'll have more long-term information that says that this is a real viable option. Insurance will cover it, and we'll see really good outcomes. I know a number of people who've had it who have done well over time. Coming off Lemtrada, if it depends on what the cell type, whether the white cells, B cells, T cells have come back or not. As far as the timing of using stem cell transplant, there may be a little pause right after Lemtrada to go straight to that. The last part of that was relapsing versus smoldering. So relapsing is you're going to have a clear-cut deficit. So you have right hemiparesis, weakness on the right side you haven't had before, lasting over 24 hours. We consider that to be a relapse. Smoldering is, I know I'm just not walking quite as well. It's not that my leg has all of a sudden become weak throughout, or my cognition, I'm just off. I'm not feeling right. I'm not feeling well. And that's sustained over time. That's more smoldering, pura kind of MS than relapsing disease.
Thank you. Do you see a timeline for when stem cell therapy will be approved for MS? And is there any progress with stem cell therapy?
Yeah, so I always seek those out at those meetings because this concept's been around since '99 at least. And I was really hopeful, thought 5-10 years, if this works, this will be here and so on. And we're still not there. And it's one of the more frustrating parts of the MS journey for me is we just don't have consistent performed studies that will tell us yay or nay. And it's very frustrating because I think the potential's there where it can be very, very helpful. But then you have, people who go to another country and they get it. Some do well, some do horrible. Did they really get stem cells? Did they not? They paid cash. it's messy. And I wish there were just a couple of really good studies that move forward. Yes, it works. No, it doesn't. We can move on. But this is just kind of lingering for 24, 25 years now. It's very frustrating. There were a few presentations in Italy where very severe patients had received it and were stabilized or improved, vast majority. We need to give it to younger people to see how it works there, as stated, so that we don't get to the point of being more severely affected. But we'll take it if it works in any phase of the disease, as far as I'm concerned. We just need some studies that will allow us to get it approved and be able to use it.
Okay, thank you. When can we expect to be tested for NFL?
Well, there's a test now called Octave that has 18 different proteins from genes that look at myelin biology, neurobiology, neuronal integrity. It's something that we started doing last October, and the hope there is that that'll allow us to predict who's going to have an active lesion, and also to see if the disease genes are picking up in between despite them not having a problem. And serum neurofilaments is one of those 18. So it was approved, it was verified in this past August as being legitimate, that 18 gene test. So I think it's going to be used more and more. There are a lot of projects going on to see how we can best use that, maybe identifying progression, and maybe predicting a relapse despite being on treatment, because there have been some cases where patients have had an elevation in that score, that gene score, a month or so prior to there being an actual relapse, and could have been acted upon maybe. That's the hope, that we can get to that point.
It's spelled as Octave. It's pronounced as Octave.
Yeah, it's Octave, but to me, if it ends in an E, the last vowel has to be long. So
well,
that's
I really glorified it one day when I called it Octave. So anyway, we did, MS Views and News did a program with them online last month, I believe, in September at the beginning of the month. So you could learn more about that entire product. From
very
our,
exciting.
From our YouTube channel. It was a very in-depth panel that they had online, and one of their medical directors. So, all right, next, what's the latest for nerve pain management? There's
just a slew of different things to try, from the anti-seizure medications and newer ones all the time. We try to stay away from narcotics. Sometimes we have to go that way. There's one narcotic that also has an indication for nerve pain. TENS units, red light therapy, physical therapy, heat, massage. I mean, a lot of things, because you can help the muscle that's compressing the nerve. But there are anodyne therapy if it's in the feet. There's a lot of different things. There's nerve ablation if it's coming out of the spine. So there are a lot of different modalities to look at. As far as latest things, I'm not sure of anything that's come out in the last little bit. That doesn't mean it's not there, but I'm not aware of it.
Thank you. What options are available for SPMS active and non-active?
So SPMS, or secondary progressive MS active, is treated just like a relapsing patient because they're having active disease. So anything's on the table for SPMS active. Inactive, if a person continues to progress, then it just depends what their history is with DMT, because I think some people can be stabilized with the DMT despite it being inactive, and that's not anything that's been proven, but you have to have a long study to do that. But we've had some patients personally trying to aggressively manage symptoms in SPMS inactive, really try to get at the things that are troubling them every day. But there's not anything grand that's promised right now to work on SPMS.
Thank you. Next one is, will biomarkers be a regular part of the MS treatment?
I think for sure. And I think we're kind of using the Octave test. We'll see. I mean, it's only been out a year, and we looked. No, the first test isn't the most important. It's following it over time to see how stable the genes are and how predictive it is. So we're still not sure of the full benefit of that test, but we're using it pretty regularly. And I think serum neurofilaments trying to get approved just as a test, a standalone test, and commercially available for a lot of people. So I think biomarkers are finally here. and they're only going to get better with a little bit of time.
Next, person wants to know why you are not doing a stem cell study.
Well, I don't have a lab that can generate stem cells from a given individual, and I'm not independently wealthy to fund such a thing. And that's part of the problem, is that we're blessed to have pharmaceuticals available. It's definitely changed the course of this disease in many ways, and they fund these clinical trials that have led to a lot of our understanding of MS, independent of their use in MS. Just our knowledge of MS has been so much broadened by the trials that we've benefited from. But who pays for a stem cell study? It's not a pharmaceutical company. It's stem cells.
Ask the Mexicans.
So the government, and of course they're saddled with a whole lot of things, but the government, that would be the appropriate use of government funds in medicine to fund studies like that.
Thank you. Last one from online for now is, are there any BTK inhibitors already approved and being used in Europe for MS?
No.
Okay. So now we're going to get to the audience, but I'm going to grab one from right here, and then I'm going to make my way around the room, okay?
You were speaking earlier about the doctor in Italy that was talking about the genetics of MS. Can you sort of summarize that again? And how would that be used, and with whom?
So that doctor was Dr. Hauser. He's actually from the U.S., San Francisco. The one after him was from Italy. But the gene study in MS, the large consortium in the world, has been working at this for over a decade, and have identified 230 genes that make a person more susceptible to MS. Not like you have this, you're going to get MS, but there's a higher incidence, low percentages, but definitely higher than the general population. So it's not ready for prime time yet to be tested in MS, that it's going to have the value that you get that test, that we're going to necessarily be able to act on it. Now that susceptibility to severe MS that occurs in 12 to 15% of people with MS, that test, I think, would be very valuable. But they're trying to get to the point of doing it before you ever have any signs of MS. So the intent right now is to try to screen people, but you can't screen everybody. So it's going to be people who are more susceptible, 3 people in the family with MS or this or that or whatnot, that probably will be the first ones to be tested on that and see what its value is. But there's a huge international effort looking at genes in MS and trying to figure out which we can modify our treatment depending on your gene. You're going to respond to this treatment or that treatment because your course is going to be this way. So there's a huge interest in that, but we're not quite there yet. It'd be a blood test.
Thank you. Out here.
If you addressed it, it just went right over my head. So I'm going to ask. You talked a lot about DMTs, but what about active disease? And Solumedrol is all that they're offering you. Is there anything else besides a steroid therapy to treat active disease? And if not, is there anything on the horizon to treat active disease that does not have steroids in it?
So there's the way to treat relapses or the active disease when it's there has long been steroids. And not everybody tolerates steroids that well. It's not effective in everybody either. So there are some other things to do, like ACTH treatment, Acthar, or there's a generic version. And then IVIG is sometimes used when steroids and either Acthar or ACTH isn't available or hasn't been effective. IVIG is something to do. And worst case scenario is a little bit harsher on the chemotherapy side to really suppress the immune system. Ideally, we work really hard at controlling MS so that we don't have relapses. So it's really trying to make sure on the most efficacious treatment to keep that from happening. But if you have relapses, those are the ways that we treat it.
Continuing on that, I've heard from a lot that obviously there's a lot of people affected by osteoporosis. So are neurologists asking their patients who might be relapsing before they put them on a steroid to find out if possibly they have osteoporosis?
Not necessarily, because the ACTH might also contribute some to that. IVIG wouldn't, but I think people who have had a good bit of steroids in the past, we try to make sure that they get tested for osteoporosis and do that. So if you have a lot of treatments of steroids, one every blue moon, probably don't need to test it at an earlier age than what's standardly tested. But if someone's had a lot of steroids in their life and haven't been tested for osteoporosis, probably a good thing to do that.
Hi. The BTK, you said is going to be available at the end of next year. Is that going to be in addition to your DMT, or is it to replace your DMT?
And so now to replace the DMT, because its effect on relapses and such is very, very good, has a very good effect like our DMTs do on that side of disease, but may have the added benefit of also working on the microglia and stop this other progressive side of things that happen. So you might get two benefits out of one treatment. That's our hope with the BTK inhibitors. Plus, from a B cell standpoint, they don't destroy the B cells. They affect their function, but they're not eliminating them like our B cell treatments are now. And in some people, that might be beneficial. That might be helpful for them to be on that instead of another B cell inhibitor if it comes between the two.
Thank you.
You're welcome.
It's kind of two-part. I know you were talking about the medications and how you prefer the brand name. So like on, for example, Vumerity, where is that on the total poll? And then my second part is, I know we're talking about the skin itching and stuff like that. If a person's already on an antihistamine, I can't pronounce it today, but is there anything in addition if they're still having issues outside of that?
Okay, so the first one, Vumerity, at this point, still branded as far as I know. These things change sometimes quicker than I'm aware by a little bit, but as far as I know, it's still a branded product. So there's not a generic issue with Vumerity. The itching, central itching, and for that matter, the neuropathic pain, the burning, tingling, not any one medication is for everybody. And so if you're on a regimen that is partially effective or not effective, we have many, many different choices. Sometimes it's combinations, sometimes it's just finding the right one. So it's continuing to seek for one that's going to help you.
Next.
The test, the genetic test,
Yes.
will that be available for, say, my kids and grandchildren?
So the one that the gentleman in San Francisco was talking about, that's not available now. It's in probably one or two research center or in that consortium. So it's not a commercially available thing. And I think the incidence is pretty low. Again, being a family member, I think your family would be at the top of the line of people who are going to be tested when it's at all available. And the other thing would be to look on, look on the site, call that particular, you can call UCSF and say, hey, I saw something about this genetic test. I'm really interested in it. I know it's not available yet. If there's trials coming up where you want to look at kids who are in a family of a severely affected person with MS, put my name on the list, or can you tell me a little bit more about it? They probably would have more insight into the timing of that than I do right now.
And also, is there anything coming up in the future about rebuilding myelin? That's our largest unmet need, probably, is repairing myelin, or those who are, suffering with a lot of disability from MS. And there are a number of things in trial. You never know how those things go. And sometimes all of a sudden overnight, one thing gets approved that's actually worked.
the fact that they've worked somewhat to get to this phase of trials is encouraging. And it's letting us learn more about it. Even if they end up failing as a treatment themselves, we understand that there was something positive, which helps us to look at mechanisms and so a little bit better and hone in on what we need to be doing. There's a new study with an anti-CD40 medication that we're a part of that probably affects Epstein-Barr virus latency and may rid it out of your system, which may perpetuate this demyelinated state. And so hope is maybe in working through those pathways, we're going to allow remyelination to occur, because the scaffolding goes like the brain wants to remyelinate, but there are inhibitory factors, and we're trying to identify what is it that's keeping them from just pulling the trigger and remyelinating. So, yeah.
10 plus years post Lemtrada, would a BTK inhibitor be a possibility once it's approved?
I think if there's a need to receive treatment, it would be one that's acceptable like any other. If one's stable, so the majority of people at 10 years are still stable or better with their Lemtrada, and no changes or worsening, probably wouldn't add another DMT at that point unless we have some evidence, whether it's cognitive testing. Doesn't have to be a relapse or a new lesion, but if there's signs that the disease is moving forward, then I think that would be a class that might be preferential because it works on those microglia, whereas none of the others have been proven to do that.
Thank you.
Is seizure still considered a symptom of MS?
Yes, the seizures occur 5. There may be a later study now, but I would say 5, possibly up to 10% of patients with MS, my mom being one of them. So yes, seizures definitely can occur in MS from a scar that's right near the gray matter, and that sets things off. So yes, it's still a part of it. No, she had it from her MS after she had MS for 30 years, so I didn't have any epilepsy growing up or anything. But you can, unfortunately, because you have MS doesn't exclude you from having other things. So you could have an epileptic disorder and then develop MS or vice versa. It has nothing to do one with the other. But with MS believed to be related to MS, 5 to 10%.
What about the clinical trials for a vaccine to reverse MS?
There are some vaccine-type trials that have been tested against T-cell receptors to immunize someone against pathological T-cell receptors that seem to trigger MS issues. There have been some of those that have been performed. I think there's one ongoing now along that line too, a particular type of T-cell receptor. There's a lot of interest in the Epstein-Barr virus vaccine, and looking at that may be very helpful. So those are the only things I'm aware of right now from a vaccine standpoint.
Okay, the presentation has been awesome and very inspiring. I would like to just say that I want to pass on some inspiration. A person was asked, "What is your disability?" And the reply was, "I don't have a disability. I have a different ability."
That's perfect. Yeah, I like that. Yeah, absolutely. If you're affected with MS pretty visibly, you inspire the world. I mean, really. And I give this tale before of, if there's someone in the grocery store, they're dealing with cancer or bankruptcy or divorce just hit them, and I walk by them, I don't influence them one iota. If someone who has a visible disability goes by them, they're like, I can do this because they do it. And by showing up and going and doing, that changes the world. That you don't even know the people you influence. I promise you. There are people you've never met that you've influenced in a positive way. I hear it in clinic for my migraine patients or my neuropathy patients who come in, they're pretty stable, come in for their yearly follow-up, and they go, and they just volunteer this, and there are many. So there are many more who probably thought it. And they say, if I ever have a bad day, I just think about those valiant people in your waiting room who just make my day so much better. I can deal with my issues because I know that there are courageous people dealing with things greater than I have. And so you inspire the world. I promise you that. Inspire me to keep doing what I do day in and day out. So thank you.
All right, I think we are finished for the day, and I'm not coming up there, so you come on over here. You come on over here, and I'll shake your hand over here, all right? And thank you for everything, and
You're welcome.
This is a
Thank
nice,
you.
short talk.
Thank you.
So we're going to just call it a wrap, all right? I'm going to say thank you to everybody again and to all our sponsors that were mentioned earlier today, and just have a great day, and hope you all drive carefully. Thank you.